The wrong meeting. Hey, Matt, I'm gonna share first and then I'll let you take over, okay?
Can you hear me okay, and can you see what I'm sharing? Danielle?
You, and we can see your slide deck. So you're
Perfect.
all
I just,
good.
I just wanted to make sure that we had done that check. I'll stop sharing.
Oh, I appreciate it. Thank you. Good morning, everyone. As you join, can you just make sure that you are seeing your name listed in the participant list? This is especially important for the CDAs because this is your breakout session and we want to make sure that you receive credit today for attending. So to check to make sure that your name is there, you want to click participants at the bottom of the Zoom screen. And then that will pop up a list of everyone on the call. If you see your name there, then you are great. But if you're only seeing your phone number or you're not seeing your complete name, maybe you're seeing your unique name or something like that. If you're seeing that, then you want to hover over your name. You'll see an option to right click next to it and you have the ability to rename yourself. So you'll see those three little dots. If you hover over your name, click on those, and then you'll have the ability to rename yourself. And again, that's really important for the CDAs on the call, so you can receive credit for attending the breakout session. One other thing that I want to point out, we do have the possibility that people are using the link that may have came from Verinda. So if you're only seeing Verinda's name and if you're not seeing your name at all in the list and you know that you're on the call, can you chat your name in to let us know? So if you use that link, it's fine because you're here. But can you chat in your name if you're not seeing your name at all underneath the participant list so we can account for you? Because we have, right now I'm seeing 1, 2, 3, 4, 5 people listed as Verinda. So you can stay on the call, don't have to jump off, but just want to make sure that we are accounting for you. So just chat your name in if you're not seeing your name at all in that participant list.
I'm going to identify as Brenda today.
Hey, welcome.
Oh, this is unusual, huh?
I
Okay.
can rename you.
Oh, no, I don't want to be renamed. I think I can do
That's a good one.
Oh, you're so funny, girl. Oh. Well, I was just gonna log in and listen if there's any, treatment planning or questions, then, yell at me. So,
All right, thank you very much for joining us.
yeah, my pleasure.
There's an MROQC meeting.
Hello. So again, for those that are joining, you want to make sure that you're seeing your name listed in the participant list. To do that, you want to hover over like the bottom of the Zoom screen and you see where it says participant. If you see your name in there, then you are all set. But if you're not seeing your name at all, then if you can put your name in the chat so we can make sure we can account for you being here. That is especially important for the CDAs on the call because this is your breakout session. And in order to receive full credit for attending the February meeting, we need to be able to see that you were on this call as well as the call that will be later on this month. So just take a moment to do that. We'll wait about 2 minutes or so, and then we'll go ahead and get started. Thank you for identifying yourself. I'm seeing names come in. Thank you, Jade. So again, that's another point. Thank you for putting your name and Chris's name. If you're joining as a group, please chat in who else is on the call with you so we can know that we can take account for both of the CDAs in the room present. All right, thank you, everyone. I'll say it one more time, just in case anybody missed it. Really important, especially for the CDAs on the call, we want to make sure that we have your name in the participant list. So if you have not already done so, take a moment, open up the participant list. If you don't see your name listed there, then put your name in the chat so we can give you credit for attending today's call. All right, and Anna, our wonderful admin specialist is, I think, marking you off as you chat your name in. So continue to chat your name in if you're not seeing it in the participant list so you can receive credit. So a few other housekeeping items on here is that we will provide the meeting notes after the call. And I should also note that the recording of today's session will be made available on our website after. And we ask that you mute yourself during the call so we don't have any backup noise coming in and interrupting everybody's ability to listen in on this wonderful talk that Dr. Cousins will be giving us today. And again, just want to make sure that you're seeing your name listed in that participant list. Thank you for everybody for adding your names in the chat. And we will have an opportunity for Q&A after Matt is finished with his presentation. And so at that time, we will allow you to unmute yourself, ask questions, and then also utilize the chat to ask questions as well. So we are very excited to have Dr. Cousins come and present on MROQC cannabis data. Matt is responsible for bringing this project and this idea to MROQC. So there's no better person to present this information to us. We felt like this was really important, especially with the new cannabis measure. And so we also want to provide some guidance and just allow you to access questions regarding providing education to patients regarding cannabis use. So Matt, I will stop sharing now and hand things over to you.
Okay, so this is going to be a discussion about cannabis use. This will be interesting for patients with cancer. So,
Thank you,
Yeah.
Danielle. Really appreciate the opportunity to speak with the group today. Just Danielle, just to make sure, can you see my slides okay?
Can see your slides? Okay.
Perfect, great. So we'll kick it off then. Thank you for this opportunity again. So today we'll be talking about the MROQC Cannabis Project and trying to provide an introduction to that project for CDAs and clinical staff involved. We'll probably defer most of the chat review to the end with the Q&A. But here's an outline for the talk. I think the first question we should answer for ourselves and for the group is why cannabis? And I think a good way to do that is to review cannabis in the U.S. and in the state of Michigan, just broadly. Then we'll talk about the cannabis project in MROQC and give a little update in terms of the data that's been made available to date. We'll talk about how to talk to patients about cannabis use. And we'll review some key counseling points for clinical staff. And at the end, hopefully we'll have some time to discuss this as a group. So first question, as a way of launching this talk is, Why cannabis? Well, our patients throughout MROC are being bombarded by everything in the national media. And they obviously live in the United States, they live in Michigan, and they hear what's happening. So there's been expanding access to legal non-medical cannabis in states across the country. At present, as of this last election cycle, 24 states have legalized adult non-medical use cannabis. So cannabis is becoming much more available as each successive state makes non-medical cannabis legal. And what is this jargon, this term non-medical use, or sometimes adult use, or sometimes adult non-medical use mean? It's roughly equivalent to this term recreational, that I think is more something that is used in our common speech. But really it's referring specifically to uses that are not medical. And you may hear a fire alarm going off in the background. I can't turn that off, but I'm sorry for that interruption. So just wanted to make sure that that particular bit of information is something that is something you're aware of as we move forward. Additionally, on a federal level, there's discussions about rescheduling marijuana or cannabis. And what that would do is it would move cannabis from a category Schedule 1, where it's currently located in our national regulations, where there's no accepted medical use, to Schedule 3, which is a group of medicines where there is felt to be a potential for abuse, but it would be in line with medicines like ketamine and anabolic steroids, instead of being placed in the Schedule 1 group along with medicines like LSD and heroin. And that would be a recognition that there is some potential use of cannabis for medical purposes. That's still underway. Additionally, in parallel with all the stuff that's been happening nationally, it's important to recognize what's happened specifically in Michigan. As Michigan legalized medical and non-medical cannabis, medical cannabis was legalized in 2008, and then non-medical cannabis or adult use cannabis was legalized in 2018. There's been an explosion of centers that serve the cannabis industry across the state of Michigan. The blue dots on this are going to be the adult use cannabis retailers. So those are the places where a citizen of Michigan would go to purchase cannabis. And those, along with the small Class C growers, make up the largest two groups of the active licenses that have been provided thus far by the Michigan Cannabis Regulatory Agency. So at this point in time, or at least in this early this month when I checked, 2,256 facilities across the state of Michigan were serving the various needs of the cannabis industry, from large to small growers to individuals or companies that provide transport for cannabis, groups that would be designated for consumption, or groups that do QA and processing of the cannabis as well. Just as a comparison, there are 524 McDonald's locations in the state of Michigan at the end of 2024. So 4 times as many cannabis facilities as McDonald's is in the state of Michigan. So patients are confronted with, expanding cannabis industry. They see commercials, they see billboards. And so that's one level of the complexity our patients are faced with when thinking about cannabis. But additionally, we have kind of grown beyond what I'll initially describe as the modern view of cannabis, which is you have a cannabis plant, it makes some flowers, and then we take the buds from those, and those get chopped up and rolled into what is frequently called a joint. And that is kind of, I think, the view of cannabis 1960s, 1970s United States. I think that's the bulk of what a lot of people have had in their mind historically when they think about cannabis. But in the face of this expanding cannabis industry with processors and retailers on every corner, now we have what I would say is kind of the postmodern view of cannabis products, which is really any and everything you can imagine has now been considered as a way for patients or individuals who may not be patients, citizens of Michigan or other states to partake in cannabis. Patients still have access to buds, and that's one of the more common ways that cannabis is still purchased. But there are salves and lotions, there are patches for delivery of cannabinoids, there are makeups, there are various waxes and resins that can be prepared through processing cannabis and extracts from cannabis in different ways. And they all have different chemical compositions. There are CBD, which is CBD is one of the common cannabinoids in cannabis, infused cookies, THC infused cookies as well. That's the principal psychoactive component. There are preparations of cannabis that are made into capsules or brownies, energy drinks and waters, gummies, all kinds of things. And very high potency extracts called RSO or Rick Simpson oil are also available. And that's something that comes up a lot when discussing cannabis with our patients as well. So lots and lots of product diversity, lots and lots of variation in product composition is something else that patients will sometimes be aware of and ask questions about in clinic. Additionally, it's important to consider the size of the cannabis industry, not just in terms of its brick and mortar locations, but also in terms of its contribution to the economy, I suppose, or the dollar value of it. This is data from the cannabis regulatory industry for the month of December 2024. And I think it's very striking just to note that roughly $250 million were spent on cannabis in the state of Michigan in the month of December 2024. And that's just the adult use. This is medical marijuana on the other side. A little less than $1 million was spent on that. So the adult use sales far outweigh the amount of cannabis that's being sold for specific medical purposes. And like I said before, you'll note flower or flower buds, they still are the most common way that individuals might purchase cannabis. But there are many other preparations that are also available, various types of infusions, there are vapes, and there are concentrates. So we have a growing push for cannabis access across the country in various states. We have considerations of adjusting the regulations around cannabis, which would have profound impacts for its accessibility. And then we have very complex product diversification happening, very complex product availability for our patients in the face of this growing industry. Additionally, there's lots and lots of information about cannabis out there in the popular media. And a lot of what I would say are the most powerful anecdotes in terms of the use of cannabis or health benefits of cannabis, I think are in many cases very much focused on cancer. There's a powerful book. Actually, there's another book as well by Rick Simpson, in which he, in addition to a number of other topics, covers his success as he purports in treating some squamous cell carcinomas that were on his chest with a preparation, a whole plant preparation extract that he has been named Rick Simpson's oil. And he describes successful treatment of his own cancer with that product. I guess more recently there was a documentary, and there have been others as well, but this one came from Netflix called Weed the People, which describes the journeys of a number of different patients who explored cannabis and cannabis use while they were addressing a cancer or tumor diagnosis. That's, I think, since been transferred over to Amazon Prime for your viewing pleasure, should you be interested. Also, some of our research where we've asked questions of dispensaries as far as how they might make recommendations to patients, we found that dispensaries, should a patient happen to go and ask questions, they might make statements like this: if you take Rick Simpson oil, your cancer will shrink and shrivel up. It's cool to see that miracle happen. Or Rick Simpson rubbed cannabis oil on his skin cancers and they vanished. Or I know what RSO, which is Rick Simpson oil, did for my mother when I used RSO to treat her cancer, and I want to help others too. Google, this is just a small snippet of what you could find on the internet in terms of information about cannabis, particularly with an eye to patients with cancer. But if you Google around, you'll find other anecdotes and statements, some of them quite powerful. and as we'll discuss further later on, not backed by scientific evidence. So patients ask lots of questions when they're in this environment, the current environment that exists surrounding cancer. And if you have heard any questions or gotten patient questions through your clinical experiences, I'd encourage you to shoot those into the chat, and perhaps we can review them at the end or as we go. But I think these are some questions that I've had patients ask me in clinic when discussing cancer diagnoses and cancer treatment. I read an article on the internet that said that doctors were hiding proof that cannabis cures cancer. Is there any truth to that? I cured my mother's cancer. She got chemo and radiation too, but I know that it was cannabis. I think that my son should skip the chemo and the radiation, just take the cannabis. What do you think about that? Or could cannabis shrink my cancer? My son told me that cannabis could cure my cancer. Can it? My nausea just won't go away. So no matter how much Zofran I take, should I consider cannabis? I have terrible pain. Could cannabis help me? Would you use cannabis with chemotherapy and radiation if you had cancer? I took cannabis while I was getting chemo and radiation. I think that it helped me avoid that feeding tube. And cancer has caused me to have terrible anxiety. Should I try cannabis for help? So our patients are asking us questions about cannabis. And again, if you have any additional questions that you've been asked, please feel free to share those. We'd love to have them. Thankfully, our colleagues in ASCO did work to produce a guideline recently based on the available data with regard to cannabis and cannabinoids in adults with cancer. You know, this is something that had been anticipated by many in the field for quite some time. And so there is a relatively small amount of actual high quality scientific data to support various uses for cannabis that our patients might claim or suggest. But based on 13 systematic reviews and 5 primary studies and reviewing the literature, this is the principal table from this work. And really the only beneficial use of cannabis was seen in the management of refractory chemotherapy-induced nausea. And there was weak data in favor of a benefit from cannabis products given in the form of dronabinol or nabilone, commercially available cannabis products. So that was one thing that probably we already knew had the strongest information in favor of it based on the 1 or 2 clinical trials. They also noted that there was not strong evidence in favor of cancer pain management with cannabis, improved sleep, addressing poor appetite in patients with cancer, management of anxiety or depression. And in terms of quality of life, there was some concern from these researchers that the cannabis may actually make the quality of life worse or may negatively impact quality of life. So in this place where we have a large industry, we have lots of access among our patients to a very complex pool of products and lots of anecdotes. We have this data, and that is kind of the environment in which the MROC Cannabis Project is functioning. So I'll provide a little bit of an update about where we are with this project at this point. So as I said earlier, in 2008, medical cannabis was legalized in Michigan, and in 2018, adult non-medical cannabis was legalized in Michigan. Initial cannabis questions were introduced to the questionnaires from MROC to a subset of the sites in 2020 to look at frequency and use of cannabis and just general use. And then in 2022, some expanded questions were added to look at mode of administration, why patients were using cannabis, active ingredients, and provider engagement. And then looking at cannabis use during treatment. A presentation in the form of a poster at Astra was presented in 2023, and then another presentation in 2024, an oral presentation from the bone metastasis group. And then more recently, introducing the breast performance measure and development of an education document. So a brief review of some of the data that we have from some of the earlier questions that were introduced. So this is looking at project on the left versus the different responses that were possible: no, no answer, prefer not to answer, and yes for have you ever used cannabis. And I would recognize that some of the patients we don't have an answer for probably didn't get the form or were enrolled in MROC before the questions were introduced. But what we find is that a significant number of patients in all of the groups are will note that they have used cannabis in the past. And when we look within those patients who endorse a past use of cannabis, and here we're looking at the number of days in the last 30 days the patient used cannabis against the various projects. We note that really quite a few of the patients are using the cannabis all 30 days. It's very similar to the number that are using cannabis less frequently. And then there's a smattering in between. But it does appear that there's a significant population, not only that have used cannabis in the past, but that continue to use it regularly at the time they enter into MROC. Looking at the next question, which really is trying to assess which one of the ways or which way the patients were using the cannabis most frequently at the time of that initial entrance into MROC. We're looking at the ways that the patients were using the cannabis and against the projects again across the top. And patients are given the opportunity to select from a number of options, and then there's also free text in this as well. But what we note is that a lot of individuals are eating it and smoking it, and a fair number are applying it to the skin as well. And less frequent as you move down the list from there. Additionally, we note very quickly that our patients in the bone metastasis project and the breast project seem to be more likely to eat the cannabis than smoke it, whereas the opposite seems to be true in the lung and the prostate group. There's lots more to dig into this, but some general tidbits I think are very valuable, even with just a cursory look at this data. The next question we had asked was, what is the major active ingredient in the cannabis product that you use the most? And some active ingredient choices are provided on the left against the projects. And we noted, I think the most interesting group here, and we didn't split these out for this presentation, but when we split them out, there's a large number of individuals who don't know what the makeup is of the product that they're using. And that's something that's very interesting to explore further. And a fair number of patients are using, a product that is high in THC or the psychoactive component. That seems to be the most popular, whereas fewer patients are using CBD alone, or more anti-inflammatory, a product that is believed to be more anti-inflammatory, and a fair number using mixed. Just a brief glimpse by way of review of the 2023 breast abstract that was presented in poster form at Astro, looking at cannabis use history, finding a large number of patients that had used the cannabis over the last 30 days, looking at that distribution, which is very similar to what we saw in the data that I just presented. And when we split out the I don't know, about 20%, a little more than 20% of patients did not know what the ingredient was that was the main ingredient in their cannabis preparation. And when looking at predictors of cannabis use in Table 1, we found that age was an important predictor, as was smoking status. That fell out, as well as Hispanic ethnicity. So definitely more questions to ask as we explore these types of questions and analyses in other projects in the future. Patients noted insomnia, anxiety, pain, nausea, fatigue, poor appetite, and recreational as the main reasons why they used cannabis in the breast group. More recently, we presented data from the bone metastasis project at Astro in oral presentation form. And the goal of this talk was to look at the relationships between cannabis use and opioid use, given that there's many in the cancer space who have suggested that cannabis might be a replacement for opioids. And what we found is that cannabis use and higher pain score actually predicted opioid use. So we found higher opioid use rates among those using cannabis or those with higher pain scores, which makes sense. And when other variables were included in the model, we continued to find that cannabis use and opioid and pain score, they continued to predict for increased concern, increased odds of opioid use, as well as NSAIDs, higher metastatic disease burden. But this is the opposite of what you would expect to see if cannabis was being used as a replacement for opioids. It looks instead that patients in pain are seeking all options for managing their pain. But more to come on that. So a performance measure for the breast project was recently introduced. At least 50% of breast cancer patients who report using cannabis in the past 30 days will be provided an MROC cannabis education document during treatment. And thanks to the MEqual team, Dr. Dykstra, Dr. Dominello, Dr. Mershwa, Dr. Covington, Danielle, and Melissa for their very important contributions as well, along with many others. But we prepared a document to help educate our patients, information that we think is the most important among the large amount of information that is available. So considering all the context that we've reviewed today and thinking about MROQ's goal to improve quality and work on this measure and education, I thought it would be important to talk about talking to patients about cannabis use today for just a little bit. So I think it's important for us to start this by thinking about what are some barriers that prevent members of the medical community from communicating with patients about cannabis. And this is another point which I think is, if you have any key barriers that you've noticed in your practice or your dealings with the clinic and with patients, feel free to share those in the chat as well. But I think when you think about the barriers, it gives you a lot of insight as far as how to talk to patients. I think it's important that we know and recognize the context of our cannabis discussions. And that's why I tried to review a lot of the context with you today. And it's important to recognize some key features of the audience. Most patients who use cannabis, they really want to talk about cannabis. It's just a lot of times they've had a bad experience with a medical provider in the past. And so they're sometimes somewhat skeptical when asked questions about cannabis. Many of them have very strong opinions, sometimes from their understanding of experiences that they've had, or their understanding of the experience of others close to them. So it's important to be aware of that. Patients of all types may be using cannabis. I don't think you can look at someone and say that's a cannabis user and that's not a cannabis user. I don't really like the term cannabis user anyway, but I think we don't have to use pejoratives. But anybody can be using cannabis for any number of different reasons or with any number of different goals. Patients often expect clinical staff to know less about cannabis than they do. So sometimes they're reluctant to ask questions just because they don't think you can actually help them. And so I think educating yourself is valuable. So in talking with patients about cannabis use, I think many times it is helpful, particularly if there's any pushback or signs of patient anxiety or concern over your questioning. I think it's good just to have in your back pocket a few sentences that you say, and this is a little bit overly worded probably, but something like this. And cannabis is in the news and it's highly available. Patients with cancer often ask questions about cannabis. We hope that your answers will help us improve the care that we provide to patients with cancer by helping us better understand cannabis use characteristics in the patients that we serve. Would you be willing to answer questions about how you use cannabis? And this makes it less about them and more about you trying to help others. And I think the large majority of our patients really like the idea of being able to help others by answering questions. And then I think there are some key counseling points that are very valuable for clinical staff in discussions they may have with patients. And I think many of these are really taken from that educational document, which can also be something you use as part of your own efforts to educate yourself along with coming to this talk today. But smoking should be avoided. We would say that generally we would prefer oral and sublingual routes to inhalation. The American Lung Association would be in strong support of statements to avoid any form of smoking. And there are risks that have been reported in the literature from vaping as well. The lungs are not meant to be a way to absorb chemicals. Time to onset of effects of cannabis can be variable based on the preparation and mode of administration. So when you eat cannabis, it can be a long time till it actually acts to its fullest. So it's important, I think, to recommend that patients start with a low dose of cannabinoids if they're taking cannabis. Usually I recommend 1 milligram. Start with a low dose and increase slowly. And don't redose if you haven't felt an effect until at least 2 hours after taking your first dose, as you're trying to figure out what dose you would like to use. Patients should only use cannabis products purchased from reputable establishments. I think it's very important that the products that patients are using have laboratory analysis data on them for safety. Recommend evidence-based therapies for symptom relief first. So we don't have data to tell us that cannabis works better for managing any of the indications that patients consider using it for, or have suggested using it for, or have documented use using it for. We don't have any evidence that says that cannabis is better than the evidence-based therapy. So we have to use the evidence-based therapies first, or at least we should recommend that. Patients should be encouraged not to drive while using cannabis. It's important that they protect their cannabis supplies from others, particularly very young and elderly individuals who might accidentally eat the cannabis-infused brownie. Be aware of variable state laws. And if you take your cannabis supplies that you purchase legally in Michigan and drive to South Carolina, you now have a large quantity of an illegal substance in your vehicle. And so it's important to recognize where you are and where you're going. And the laws are very different from state to state. There are associations between cannabis use and heart attack and stroke. Recent data suggests that individuals who frequently use cannabis, that population seems to have a higher risk of heart attack and stroke. Cannabis may worsen depressive symptoms and quality of life. And then, of course, we always have to be aware and address the questions about cannabis as a cure or treatment for cancer very clearly, in noting that there is no data that has been done in humans, that no clinical data that suggests that cannabis cure or treat cancer or is a substitute for evidence-based therapies. It's important to recognize that. In terms of future directions for the MROQ Cannabis Project, we're looking forward to doing some initial analyses of data regarding patient and provider interactions. Some of the more recent questions introduced, looking at a provider survey, and looking at working on breast manuscript and bone metastasis manuscripts along the lines of the abstracts previously presented at ASTRO. And then looking forward to working on our first foray into the prostate and lung data. Prostate questions were introduced later due to the launch of the prostate project, and then the lung group had smaller numbers. So that will be something we'll be excited about looking at in the future. But thank you again for the opportunity to chat with you today. And thank you to MROQ as a whole. It's been wonderful just to be given the opportunity to work with such a wonderful team. So thank you. And with that, we'll stop and see if anybody has any questions.
Thank you so much, Matt. You do have one question in the chat that came in. It was a question or a comment made by one of the CDAs, our wonderful Caitlin Baldwin from Munson, regarding barriers. She put a lack of documentation in the EMR regarding cannabis use and what is used. Also, time of clinicians to spend with patients is limited, and cancer treatment takes priority.
Mm-hmm. Yeah, I totally agree with that. We have to focus on treating patients and getting them on the right therapy. Totally hear you. And we don't have good ways of recording cannabis use in the EMR at all. Even if someone does mention that a patient's using cannabis, what does that even mean in 2025? There's 100 different things that can mean. So it's a very, very complicated thing to discuss, and clinicians don't have much time. Totally understand. I think it's important in some circumstances to make the time when you can, but there's always going to be limitations with time. Any other questions or thoughts? Those are wonderful examples of barriers, though.
Feel free to unmute yourself or type your questions directly into the chat.
Hey, Matt, this is Robin. I have a question for you. Is there, in collaboration with MedOnc, is there any, interest in them discussing cannabis use in that regard, since they're more the chemotherapy line of things, or is this just been kind of our interest?
I mean, I would say that any doctor who is addressing the care of patients with cancer should probably be interested in any supplements they're taking. You're right. I think the medical oncologists frequently, when they're giving medications, they will be a little more focused on asking questions about medicine, supplements, just for concern about interactions. That something we don't really have time to get into today would be the potential for interactions between cannabinoids or the many other products, chemicals that are inside of cannabis preparations. But there is potential for interaction, alterations in how the body handles different medicines. That data mostly comes from the anticoagulant space, medications like warfarin, the data that we have available. But I think generally speaking, it's good when you're causing symptoms or addressing symptoms to at least have some idea what patients are using to address those symptoms already, so you can make sure you're doing the most you can to help them address those symptoms, whatever they are. So if they're already using cannabis and opioids and a lot of other medications, I think it's always the doctor's job to try to see if we can optimize that in any way. And I think we're always going to get questions about adding on cannabis. And when we do, a lot of times it's the doctor in the room or the nurse in the room or whoever's in the room with the patient when that discussion is brought up, that sometimes has a real valuable opportunity to help make sure the patient stays as close to an evidence-based track as they can for as long as they can. And I think there's a lot of value in that as well. And also, I mean, I've seen toxicity in patients who just tried it on their own without any insight and went too far too fast. And I think it's good to at least have some understanding to be able to give a little cautionary note to someone who might be about to make a mistake and end up with some really bad nausea for a while, or end up in the ED.
Yeah, very scary. Yeah, thanks.
Good question. Wonderful question.
We have another question that just came in the chat from Amy Coleman, Bay Region. She says, I have had issues with patients not wanting to answer or even participate as our documentation is part of their medical record. Their primary concern was issues with their job. What type of verbiage would you use to alleviate their concerns?
So I think it's always challenging when you're talking with someone who has a legitimate concern about their medical record. And the relationship between their medical record and their employment. Just because something is legal in the state of Michigan doesn't actually mean that your boss can't fire you for using cannabis if it's something that's contrary to the practices of that industry or that position. So that's a legitimate concern for patients to raise. Typically, when patients ask me questions like that, what I tell them is that their medical record is privileged, and their medical record should not be made available at any point in time to someone who is employing them. And if it is, that is not okay from a legal standpoint. And so that medical record should be privileged and protected. I feel like that is a pretty strong statement and it's an accurate statement. So that's typically what I tell patients. But if anyone has concerns about it being in the medical record, you can know things and not put it in there. And that's okay too. And so sometimes if patients have legitimate concerns like that, I hate to say don't document, but if someone tells me not to put it in there and they tell me something, then I don't necessarily think you have to out them in a way that they're concerned. Sarah, did you have something?
Right, any other questions? I'll throw one out there, Matt, for you. Knowing that a lot of people, it's a certain comfort level in being able to speak to patients regarding cannabis use. You don't want to provide misinformation to add to that, information that's already out there that can be misleading. Do you have any good places where people can go to get up-to-date education on what's out there? Like you cited a lot of research that's out there. We know things change often. Do you have any reliable resources that you would tell people that they can go to use to feel comfortable that they're providing accurate information?
In the bottom of the original information sheet that we created at University of Michigan, that actually was kind of the forebear of the MROC sheet, we listed some links to some good websites. I think my favorite among those is probably the Memorial Sloan Kettering website. It gives a lot of good information about cannabis that's in line with the data that's available right now. That's probably my favorite. And then there's an information sheet on the NCI website as well, which I believe to be accurate and is a good resource.
All right, we do have two more questions that just came in. So from Chuck Mayo, this says a caveat is there is that there are drug tests required as part of employment centers like University of Michigan cannot employ people not passing drug tests, including for cannabis. Basically, it's a federally classified drug.
Correct. And in that case, if you're being tested, then you would not want to encourage patients to use cannabis. You can't there's no way around that.
And then another question that just came in from Kelly. How would you respond to some of the FAQ questions that were on the first slide?
That is a good question. Let me go back to sharing. A little too far. That is a wonderful question. For this one right here, about reading an article, this comes in many ways from some of Rick Simpson's work, I typically approach it from the standpoint of telling patients that if there are really, really good cures for things, they get out. And it's really not a situation where this is going to be information that's going to be hidden from the public if it's available. And I tell them that I've reviewed the data and there really isn't any data out there that supports the claim that cannabis is going to cure their cancer. We have to sometimes delve into the difference between preclinical and clinical research, which I'll do sometimes. There are studies that have found that cannabinoids will cause cancer cells in a petri dish to die. And so I typically talk about the differences between cells in a dish and cells in a human body, and how those are very different situations, and how many things that kill cells in a dish don't work in the human body, which is definitely true from scientific research and drug target discovery, and explain it that way. My nausea won't go away no matter how much Zofran I take. We talk about other evidence-based antiemetic strategies, may trial those, and if those don't work, then sometimes we will discuss cannabis if I happen to be in a state where cannabis is legal and they can access it. I cured my mother's cancer and she got chemo and radiation too. We talk about I usually ask questions about whether the degree to which the evidence-based therapy might have participated in the cure that thankfully their mother achieved. And we talk about that some. And a lot of times patients will soften somewhat to maybe that other stuff that wasn't cannabis did actually help my mother and help cure her cancer. Could cannabis shrink my cancer? This is kind of directly in confrontation with some of the stuff from Rick Simpson's work. If you answer this honestly, but I simply say that we don't have any clinical evidence to say that cancer can be treated or should be treated with cannabis. And this one is similar. We're basically reinforcing the concept that cannabis is not a cure for cancer in multiple different scenarios. I have terrible pain. Could cannabis help me? I will pull out the ASCO guideline for this one and note that we don't have good data to suggest that cannabis is going to be the best treatment for their pain. And we talk about evidence-based measures and potentially experts in pain control before we would think about cannabis. Would you use cannabis with chemotherapy and radiation if you had cancer? Typically, I I try not to answer questions that actually ask me to say what I would do as a doctor. And generally, I try to tell patients that the goal here is to find what works for you and not what works for me and apply it to you. I took cannabis while I was getting chemo and radiation. I think it helped me avoid that feeding tube. This gets at the use of cannabis for managing some of the symptoms of treatment. There are products available that patients can use to help with nausea that come in pill form that are easily accessible. So those are options for patients who have chemo refractory, treatment refractory nausea or other. That's really the main place where we have data is in nausea. And cannabis caused me to have terrible anxiety. Should I try cannabis to help? In my experience, clinically, trying cannabis has often not helped with anxiety and for patients. And typically, we try to work again from the space of evidence-based medicines and long-term management of mental health issues, as opposed to adding cannabis and just throwing cannabis at a problem and not really adopting a thorough and complete approach to managing mental health, which I think is really important. So counseling sessions, our counseling therapy group sessions, talking with other patients about their cancer experience, the introduction of evidence-based medicines directed at their mental health, and in more severe cases, consultation with providers with expertise in managing mental health, potentially mental health at the time of cancer diagnosis as well, if that's available, which it is at some academic centers. Any other questions, comments, concerns?
Any additional questions for Matt before we move on? All right, not hearing any, Matt will give you a virtual hand clap. Thank you so much for coming today and presenting. This is amazing work, and we will provide the slide deck, like we said to everyone, after the recording also will be placed on our website as well for those who are not able to join. So please share the link when you see that it's posted with other members at your facilities. We want to make sure that this information is being disseminated. It's important. It's a part of one of our quality measures, like we mentioned. So we want to ensure that people are comfortable talking to their patients. So thank you again, Matt.
Thank you for having me. Great to be here. And wonderful questions, everyone. Good luck.
All righty. So let's just go into the last items that we have to discuss before we are finished for the day. So really to our CDA team, but this also applies to some of our other abstractors who enter data for us. So we have launched new reports in Power BI. So I know we've worked closely to make sure everyone has access to those new reports, being able to log in. But if you are experiencing issues with logging in, please reach out to support. We will be transitioning all of our database reports to this new reporting system. So we really want to make sure that you're able to get in without issues. We have our wonderful analyst team that are offering office hours tomorrow to try to troubleshoot with any tech issues as far as getting in or just general questions about navigating through the reports. We will be sending out that office hour link again. It already has gone out once, so you may have already signed up. We know people are signed up for tomorrow, but they still have some slots available. And then, of course, we have our big virtual meeting on the 28th of this month. So please register. And as I mentioned at the beginning of the call, in order to receive full credit for the February meeting, you must, of course, attend your breakout session and also attend the virtual meeting. I will also just say one more time, please, if you have not already put your name in the chat to make sure that we know that you're on the call, take a look at the participant list. If you don't see your name listed, then put it in the chat. If you've already listed your name in the chat, there's no need to do that again. So just take a moment. Make sure you're seeing your name there. If you already added it to the chat, then don't do that again. But if you haven't, please go ahead and do so. We also have the link out there for you to order MROC brochures. And so you just go ahead and tell us what you need, and then we'll provide those to you by mail. And then, like we already mentioned, the meeting slides and the recording will be available on the MROC website. And lastly, we love to receive your feedback about how you've felt about today's session. We always want to improve or provide additional topics of interest for the group. So if you have your phone, you can scan this QR code. You can go ahead and give us feedback. If you don't have your phone available, again, we will send out the survey link so you can take a moment to just offer us your feedback about today's meeting. And that is all we have for today. Thank you so much, everyone, for joining us, and we look forward to seeing you all later this month. Bye.